Back to an Ask Me Anything with Dr. Twyman. Today I had the pleasure of recording an interview with Dr. Jack Wolfson, the paleocardiologist. It's going to be for a heart attack and stroke prevention summit that'll be launched in February of this year. Talked a lot about the endothelium, the endothelial glycocalyx, and got to talk about some quantum topics. So we talked about circadian biology, talked about structured water, aka coherent domains. So if you're interested in quantum biology or the vascular testing that I frequently talk about with my patients at Cardiology, that summit interview will be out in February. So once I know more about it, I'll release information about it in my story. So welcome to those that are joining tonight. Always great to see familiar faces. We had a lot of good questions answered tonight. A little bit of housekeeping. I'm still accepting new patients at Apollo Cardiology. I am booking out until the beginning part of January at this point, if you're interested. My application on my website is drtwyman.com, and a member of my team, generally Cassidy, be the one that reaches out to you after setting up a Zoom call with her to figure out what are the things you'd like to work with us for and make sure that we're a good fit for you. Right now, we have a couple-week backlog on that. We're trying to work through that, so we appreciate everybody's patience with that. After the recent Dave Asprey podcast, we had another surge of people interested in working with us, so we're working our way through that. We're a very capable team, but we're a very small team, so it's just myself, Cassidy, and Dow that run all of Apollo Cardiology. So pretty amazing because we have patients from literally all over the United States, and we've had a couple international guests in the past couple months. So if you're still interested in working with us and you've applied already, we're in the process of getting everything kind of squared away and trying to move those appointments up with us on our kind of onboarding calls. If you haven't yet applied, still go ahead. I'm still accepting patients at this time, but my first available appointments are going to be in the new year. All right, a whole bunch of questions tonight, so let's see what we can do. All right, so not my area of expertise. Somebody says that they took the COVID-19 vaccine and now they regret it. How detrimental would it be to me? That's an unknown. I would need to know a lot more about, your history, labs. Do you have vascular disease? Not my area of expertise, but the spike proteins can damage the glycocalyx, so you want to look at the things that affect the nitric oxide pathways for your vascular system. And look for somebody online who's actually a COVID expert or somebody who deals with a lot of long-haul COVID. Since I'm in private practice and haven't been in the hospital in 5 years, I don't really see that many patients with COVID injuries or native COVID infections. Question, how do you lower high triglycerides naturally? Depends why they're elevated. Sometimes they're elevated due to insulin resistance. So look at your fasting glucose, your A1C, your HOMO-IR scores that I understand if you're insulin resistant, and that's driving the high triglycerides. Some people it's due to too much alcohol. Some people have issues with lipoprotein lipase, which you can assess on a GB Insight panel to see do you have a gene that affects the fat metabolism and would cause high triglycerides. Things that would, quote, naturally lower it. High dose omega-3s tend to help lower triglycerides, but there are no guidelines that say that you should try to lower triglycerides other than doing lifestyle interventions, except in the case where the triglycerides are over 500 and the person's at increased risk of pancreatitis, which is an inflammatory condition of the pancreas, which sometimes can be fatal. In that case, you want to use whatever tool you can. Often it's fenofibrate, but naturally, look at if you have insulin resistance. That's usually the main cause for most people. How does an ablation work, and can it be effective for treating atrial fibrillation in an older patient over 80 years old? So I'm not an electrophysiologist, but I know how they generally work. They either use a mapping catheter to figure out where the arrhythmia is coming from. Generally an AFib, it's usually from the pulmonary veins that are dumping blood back into the left atrium after picking up oxygenated blood from the lungs. They either use a cryo cold balloon or a laser to basically burn a ring around the pulmonary veins to interrupt the circuit. I haven't looked at the data recently, but in the past, generally you would need the procedure more than once they generally get a 70% success rate. So typically, people get the procedure done. 6 months, 12 months later, they may need a touch-up procedure because they may have missed a spot. So ablations are good for people who are very symptomatic from AFib and are intolerant of medications to rate control or rhythm control their atrial fibrillation. Best training video or condensed reading for understanding cardio IQ labs. There's probably not a condensed reading option. I was essentially self-taught and just reading tens of thousands of these labs over the years. But if you go to my YouTube channel, which is just drtwyman.tv, there's at least 2 videos where I've gone through my own Boston Heart Lab and Cleveland Heart Lab past labs. One of them's called like How a Cardiologist Interprets His Own Labs. They're very similar to the Cardio IQ labs. Somebody says that they have an ideal, I think, total cholesterol range. What's too low? Should LDL really be below 70 with the previous stroke and MI? The newer traditional guidelines are that the LDL-C should be less than 55 in that instance. But I always look at the lipoproteins and then look at markers of oxidative stress, inflammation, as well as markers of nitric oxide that affect the underlying endothelium. So there's no too low of a cholesterol number for most people. Your body makes all the cholesterol it needs in the cells. You're lowering lipoproteins that are floating in the blood. Those are what are directly, contributing to further plaque formation in the arteries. So now there are cases where people can't tolerate the medications for multiple reasons. Just find a different agent if possible. And if you have desmosterol levels checked, if those are low, then sometimes you got to back off on the statins. But maybe use it more at a lower dose or pulse dosing in that instance. Someone's asking, am I going to write a book for providers or students? That would be a back burner project at this time. If you're interested in something like that, I would need more people who are really wanting that kind of training. There's some talk that I'll be doing something like that similar for A4M, the American Academy of Anti-Aging Medicine. I'll be attending their annual longevity conference in a couple weeks in Las Vegas. They're going to be doing a course for people to look at vascular health, and I'm going to be one of the instructors. So that might be the earliest option for that. But if there's enough people asking for that, maybe I will do something like that in the next year or two. But the stuff's moving so fast that by the time I write a book, it'll be, in my mind, out of date. So video is probably the better option. So maybe video courses. Thoughts on physical activity, coronary CT calcium scan study. Dr. Attia posted about it in his Instagram stories. Too much exercise for too long is counterintuitive. So I saw the post. I did not have a chance yet to read the actual article, but it's another article that talks about that, excessive exercise may be correlated with increased CT coronary calcium scans, but that's old news. But the real way that I would look at it is that, exercise is the best drug for anti-aging, but it is a drug. There is an overdose response. This is why professional athletes can still have heart attacks. They can be, quote, fit, but they may have not recovered well. They have high stress. They don't sleep well. They have, a lot of oxidative stress and inflammation. Their vascular system gets, damaged in the process. So just being fit does not guarantee you don't have atherosclerosis. So I got to go looking for it with either a calcium score or a CT angiogram often. But most people are not in the path where they're doing too much exercises. Most people aren't doing enough. So it's all cases where, it's, I don't want to say it's clickbait, but, you do have to look at the health of the arteries and then decide, okay, if there's a lot of oxidative stress and inflammation, is it because you're not recovering well enough from your current exercise load? Next question, can beef tallow applied to the skin raise cholesterol levels? Unknown. I don't suspect that it would. A lot of things that you would put on your skin, it does get absorbed systemically, but the lipoproteins, that are varying the cholesterol through your blood, that's coming from cholesterol that your liver produced, not from what's coming in through the GI system, and likely not what's coming from the skin surface as well. I saw this question earlier today. I don't know the context of this, but somebody says, I heard if you get a stent, there's a greater chance of hip surgery in years to follow. What are my thoughts? I don't necessarily say how those two things are related. And it depends on what medications might be used to basically, quote, take care of the stent. But the antiplatelet agents, I've not seen any increased risk of osteopenia or osteoporosis. And the traditional lipid-lowering therapies haven't either, so we need more information about that question. Question is, my potassium levels fluctuate on the higher side. Been on a atenolol, is that affecting it? I have not seen that. Atenolol tends to affect more blood sugar and tends to cause low CoQ10 levels. I have not seen it affect potassium. For the blood pressure medications that usually affect potassium, it's usually going to either be the ACE inhibitors, the angiotensin receptor blockers, or for sure the potassium-sparing diuretics such as spironolactone. So you'd have to know what else potentially you're taking, supplements and medications that might be affecting it. But potassium normally should not be high in people unless they have kidney issues. If you have end-stage renal disease or chronic kidney disease and can't clear potassium, it tends to build up. Sometimes there's certain adrenal hyperplasias that will increase potassium, but that's rarely rare. So may need a further workup if it's something persistent. Thoughts on ADMA, asymmetric dimethargenine. So it's a lab that I check in every patient every time. It's a lab that if it's elevated, typically levels over 100, it's going to have effects on your nitric oxide. Nitric oxide is the gas that dilates your arteries, prevents things from sticking to the arteries. High ADMA is often associated with high homocysteine levels. So if you have a methylation issue, you have an MTHFR mutation, you may want to get your ADMA levels checked because if it's high, it's possibly affecting your nitric oxide pathways. So how to lower it? Well, if it's a methylation issue, then you take methylated B12, methylfolate, maybe trimethylene glycine. And then if you still can't lower it, then you just start supporting nitric oxide directly with various lozenges and capsules for the most part. What should someone in their 20s that has lipoprotein a do to lower it? At this time, the only thing that effectively lowers it is apheresis. That's the only FDA-approved therapy that really effectively lowers LPA. But honestly, I've never sent anybody for it because it's a very inconvenient procedure. You got to go to the hospital, get hooked up to a machine, take your blood out, spin it through a machine, take out the LPAs, put your blood back in. And it's not a permanent fix. You got to go back a couple times a month to have that process done. Best therapies for the time being would be PCSK9 inhibitors. You may lower LPA by 30% or greater, but is that clinically significant? Not yet known. The new class of medications, the antisense oligonucleotides, the small interfering RNA molecules, they'll generally likely lower LPA by over 95% is what I've seen in most of the phase 2 studies. Phase 3 studies have not yet been released. Those are what we're waiting on. Those studies will show that if you lower LPA, does it lower the things that you care about? Does it lower heart attacks, strokes, need for stents, hospitalizations? If it does that, then those drugs are going to be very, very popular. In the interim, you just want to lower all the other risk factors that you can. LPA, if you have high levels of LPPL-A2 activity, which is a vascular inflammatory marker, if you have high levels of oxidized phospholipid ApoB, which is only currently available with the Boston Heart Lab panel, and you have elevated levels of interleukin-6, then your arteries are inflamed and likely LPA is the contributor for that. So I check that in anybody with LPA levels. And then you can work on just lowering traditional risk factors. Is your blood pressure less than 130/80? Is your hemoglobin A1C 5.1? Do you have a normal type of exercise load? Is your ApoB particles normal from an LDL particle standpoint? So lots of things to be able to be done until the newer drugs come out. Somebody's asking, what are the big guns you use if a patient has ApoB above 100 and has higher calcium? So I suspect you mean a higher calcium score. So your CT creatinine calcium score should be 0 forever, but if you live long enough, it's likely to become positive. You just want to be the later decades and not necessarily under the age of 40. If your calcium score is over 300, that's equivalent to you previously already having a heart attack. So those people should be treated like secondary prevention, even if they've never had a heart attack. The big guns, the four that have the outcome data, and that's what we're really looking for, is if you're going to use something, you want to have some data that likely is going to reduce the things you care about. Just making your labs look pretty, may give you some points, but you really care, do you have a heart attack? Do you have a stroke? Do you die earlier than you want to? That's what you care about. And those four big classes that have an effect on that, it's going to be the statins, it's going to be ezetimibe, it's going to be the PCSK9 inhibitors, and it's going to be bempedoic acid. So those are the four classes of medications that have more effect on the lipoproteins than supplements alone. Somebody's asked, what is a good ADMA number range? Under 100. Somebody liked my podcast with Dave Asprey. Anything you wanted to share that you didn't get to? I started off with it a little bit, talking about my experiences getting into using the blue blocking glasses at the beginning of the podcast. But after we hit end record, I went through a little bit more of the story of how I got the glasses, particularly the darker true darks, and how you kind of look like the Unabomber of the plane. So we talked a lot about those type of glasses. But no, I think I got out everything I needed on that podcast. So talked a lot about optimizing the light environments. Circadian biology was one of my favorite topics to chat about. And then got to talk about the glycocalyx and optimizing nitric oxide. So that is one of my better combo podcasts. Sometimes podcasts lean more towards the vascular issues. Some of them lean more towards the quantumology, but that was one that kind of got both. Let's see. So after a congestive heart failure, how fast arteries can be cleared if eat, sleep, exercise right? So we need more context on that because that's not how it normally goes. So congestive heart failure can either be due to systolic dysfunction or diastolic dysfunction. So does the heart not pump well or does the heart not relax well? If the heart does not pump well, then one of the main causes is ischemic cardiomyopathy. So you have three major coronary arteries, the left anterior descending, the circumflex, and the right coronary artery. If there's severe stenosis in those arteries and the myocardium isn't getting its oxygen nutrients, then you may develop a systolic cardiomyopathy. So will the arteries be cleared out with lifestyle? No, not by itself. Those are good ideas to start with, but you have to figure out what caused the plaque in the arteries to begin with. Why did you have endothelial dysfunction? What happened to the glycocalyx? Where are your nitric oxide levels now? How much oxidative stress or inflammation do you have? You can monitor that with blood testing. Where are your lipoproteins now? Are you on therapies that treat your lipoproteins? Are you on the supplements that have been shown to stabilize plaque? So there's a lot of moving parts for that. But if you're having congestive heart failure because of stenosis, you have to fix the reason to develop the stenosis. But, a quantumology kind of thing is that, your heart is chock full of mitochondria. Each heart cell, myocyte, has somewhere between 3,000 and 5,000 mitochondria. So if your heart isn't pumping well, you may have a mitochondrial issue. So you need to get your, light right is how I say it. But you need your circadian biology dialed in. Grounding's important. Infrared light. So you can use sunlight. You can potentially use sauna. You may be able to use photobiomodulation panels, aka red light panels, to help with that. So would need more context, but that's a good starting point for most people. All right. That's the rapid fire questions. Those are some really good ones tonight. There's a few of those I hadn't seen in a while, or some of them actually never answered in the past 4 years. So now we'll hit the live questions in your guys' comments. Any new podcast I'll be doing as a guest? They liked the Dave Asprey one. They thought it was excellent. Thank you very much. At the top of the hour, I said that I just recorded a interview with Dr. Jack Wolfson, the paleocardiologist, for his heart attack and stroke prevention summit. It's going to be in Heart Health Month, so February of 2025. I don't yet have the details on when that will be released, but I will start sharing that information in my Instagram stories, as well as my email list when I have more information about that. Probably the next big podcast I'm working on dates with her and her team is going back on Dr. Gabrielle Lyons' podcast. So it's been about 2 years since I did the podcast with her. A lot of stuff has changed since then, so she's invited me back on. So that'll be a good one for people to tune back into. Somebody's asking, if you have an elevated LPA score, can one have a long life expectancy? Yes, particularly if you have a world-class cardiologist taking care of you, from a VIP asking me that question. But it goes back to the answer that I went through earlier. If you keep vascular inflammation low, keep oxidized phospholipids low, keep interleukin-6 low, then the arteries aren't as inflamed, less likely LPA is going to damage the arteries, and even keep the glycocalyx healthy, then the glycocalyx basically repels the LPA particles from sticking to the arteries. So it is possible to have a normal long life expectancy with LPA, but things do need to be monitored and adjusted as needed based off of blood testing. Causes for blood pressure spiking up after eating. Atherosclerosis is a postprandial condition. That's something I learned from my mentor, Dr. Mark Houston. Blood is being shunted to the gut. It's not going to the skeletal muscle system. Blood isn't flowing to all the areas, in the same pattern. So I would suspect it probably has something to do with blood shunting to the gut, but, don't know. I mean, if you potentially have some type of food sensitivity or allergy, or something going on with your glucose, maybe having an effect on that. So if insulin is spiking, that's going to raise your blood pressure as well. A 24-hour ambulatory blood pressure monitor would be excellent for that situation, because then you get to see when the spikes are. This is a good question. I've had this one often. Is, can taking low-dose rosuvastatin, which is a statin, with ezetimibe, which is a cholesterol reabsorption inhibitor, cause low testosterone in males? If so, is there anything that can be done to counteract this effect? So the short answer is no, not in the greatest majority of cases. The cells make their own supply of cholesterol. The body's not waiting for lipoproteins from the liver to be delivered to them to receive cholesterol. What the body's waiting for is for triglycerides, which are energy, to be delivered to them. Not every cell can make, the cells don't make their own energy supply. You're getting the energy from the food you eat, and it gets broken down in the liver and packaged up and sent out in the lipoproteins to the cells. In times of acute stress, like if you're in the ICU on a ventilator, the adrenals and the gonads will require more cholesterol to make more stress hormones in that situation. But it's not from your LDL. It's from your HDL. It's the HDL particles that deliver that cholesterol. So is it possible? Theoretically, yes, but clinically, no, I don't typically see that. And if somebody's testosterone is low, it's often an issue that their light environment is way off. They never see a sunrise. They don't limit the artificial light, particularly at nighttime. The stress levels are often too high. They don't do enough strength training. They're drinking too much alcohol. They're sleeping 5 hours a night. Those are the low-hanging fruit. If you fix those lifestyle things, testosterone responds in kind. I tend to use testosterone as just a marker. Is the person generally getting most of the lifestyle things right? And times people are doing all those things, and testosterone's low. But just because testosterone's low does not mean that you need testosterone replacement therapy. You have to look at, do you actually have symptoms? There's a questionnaire called the ATOM questionnaire. One of my attendings at St. Louis University actually wrote that questionnaire. It's 10 questions. The more questions you answer yes to, the more likely it's testosterone that's driving those symptoms. Testosterone in your blood is just a snapshot. It's literally like a picture. What you really need is a video. Where is that testosterone going? Is it getting into the cells and activating the androgen receptor and turning on the machines that make proteins? If it is, and you don't have symptoms, you don't really care so much about your testosterone levels. But that's a little bit of a side rant on testosterone. What are my thoughts on niacin if you have heart issues? Not as useful as once thought. Back in 2012, 13, I was using it more often, particularly for people with high triglycerides, low HDL. Later, if they had high LPLA, I was using it. But the outcome trials really haven't been that positive for it, particularly for LPLA. And if you have high triglycerides, there's better things to lower it. Niacin's really hard to use for most people. You got to get doses up to 1,000, 2,000 milligrams before people have an effect on their lipoproteins. And by that, you're generally going to have a lot of flushing, this warm, hot sensation. Most time it's very uncomfortable for people and they don't want to continue the supplement. May raise blood sugar in some individuals, can increase the risk of gout. So I've found it that mostly fall out of favor for most people. Now, people have been on for many years and they're tolerating. I generally won't stop it because of that, because I haven't seen any necessarily harm if the other things are looking okay. But I'm not necessarily adding it on to many people at this time. So high systolic and low normal diastolic pressure is caused by what? Unknown just by that question. Depends on age. Sometimes that's normal aging. Sometimes that's aortic regurgitation. Sometimes that's endothelial dysfunction. Lots of moving parts on it. But typically, stroke risk tends to ride with systolic pressure when people are over 55 and diastolic pressure when people are under 55. But both are important. Somebody's just thanking me for these AMAs. You're very, very welcome. All right. So I think I got through all the questions. It's been speed rounds, as one of my patients was saying earlier today. I've been doing these AMAs or a Zoom version of this for about 4 years now. So always appreciate the time and attention you guys put into these things. I do enjoy doing them. Keeps me sharp for my patients at Apollo. And then you probably hear me when you listen to these podcasts that a lot of things that you ask me, there's the same things that the podcast hosts are asking me. So this is kind of like my sets and reps to be ready for those podcast questions that I get. So next week, we'll do the same thing, 6 p.m. Central Time. I started at the top of the hour saying that I do have availability to continue to work with me, but my first available appointments are going to be sometime in January of 25. If you've already applied to work with me, we have had a big backlog of people since the Asprey podcast, so we are working through those. So we do appreciate your patience. We're trying to move those up as fast as we can to get your questions answered to make sure that we're the right fit for you. But I will work on it to put out some longer form content in the near future on my YouTube channel. So all these AMAs, they get put through this AI filter. It'll transcribe it. And then I drop it up on my YouTube channel, which is drtwyman.tv. So if you want some of my longer form videos, that's where those hang out. So appreciate you guys' time as always, and I'll see you next Monday.